my role today is as a neurosurgeon, but I'm also involved with the brain cancer group and also COGNO, which is the Cooperative Trials Group for Neuro-Oncology, which is essentially Australasia's clinical society for brain tumours, and it's a privilege to be on the management committee of that. And to there's no greater example, I think, in neuro-oncology of where we need to collaborate than oligodendrogliomas. A couple of key concepts to talk about before we talk about surgery, and Dr. Cook alluded to a number of these. First of all, when we think of gliomas, that are tumours that occur within the brain, there's two sort of real types that we see. We see ones that are localized and form like a lump, and ones that are more diffuse, where there may be a significant lump, but we know that the tumour cells extend into and throughout the brain. And that presents obviously a difficulty for us as neurosurgeons, because we can't remove brain, regardless of whether or not it contains tumour, if it's functioning. Therefore, we need to be, as Dr. Cook alluded to, very cognizant of what we might be dealing with in terms of tumours and other treatment options before we make surgical decisions. When we look at the types of gliomas that there are, as Dr. Cook again said, basically there's two sort of ways that these tumours are graded, and that comes down to looking down a microscope at these tumours, and again I'll have an example of that. But really we're looking at two sort of parallel streams, if you like. Number one is the type of cell that it looks like these tumours are. That is the sort of normal cells that the tumour cells resemble. So be them mostly astrocytes or oligodendrocytes, and thus the names of these tumours. And then down the left there, the WHO grade. So we talk about the grade of tumour being how aggressive a tumour is, how likely it is to recur, and if/when it is going to recur, how soon that's likely to be. And this was certainly the way it was from the 1920s, as Dr. Cook said, right up until about 6 years ago, when the World Health Organization, or WHO, revised their guidelines to incorporate some other measures that have become important in the diagnosis of these tumours. So now, rather than us just, the diagram's a little bit more complicated, where we're looking at, first of all, the type of tumour we think it is, but then doing a number of molecular tests. So firstly, a test called IDH. If that's what we call mutant, that is that it's abnormal. That's actually a favourable thing for tumour cells to have in terms of how likely it is for the tumour to recur and how quickly it is likely to grow. Then within the tumours that have the IDH mutation, we then further stratify these tumours based upon a test called 1p19q co-deletion. Whereas before, the oncologists used, the neuropathologists used to look at the cells and say this certain pattern of cells looks like a tumour that will behave in a certain way. Now we actually use this test to classify tumours as oligodendroglioma. So that's very important, and certainly this the evolution of this had a big influence on me as a young neurosurgeon training and choosing to get into neuro-oncology. And in fact, this is we all have those patients or those moments in our lives that certainly we feel like we shape us a lot. And this was a patient where I was on call as a fairly junior neurosurgical registrar. I got a phone call from the emergency department, and in fact, Dr. Cook was the consultant on call, and about this patient, a 34-year-old male who just had a history of headache, but it was fairly severe headache, and it was enough that that they thought he needed a CT scan. And the CT scan looked like this. There's this large lesion in the left frontal lobe. There's some contrast enhancement around the rim of the tumour, but there's also some calcification of the tumour. So again, a little bit of pattern recognition, but we could narrow this down to a couple of types of tumours based upon the CT scan. He went on and had an MRI that basically showed the same thing. And then the first, I guess, one of the most important, a few of the important surgical principles in terms of deciding what sort of surgery to do came into play before this patient went on and had surgery. So a few things: he was relatively young, therefore he was likely to be able to tolerate surgery very well. The tumour's in a location that's favourable for us to operate on. This is an area where we can remove tumours and there's usually not any neurological deficit. And then thirdly, he was well from a neurological perspective. And again, those two things go hand in hand. The location of the tumour determines what function may or may not be lost. So in this case, with this being in the frontal lobe, it's usually somewhere that we can operate on relatively safely. The left frontal lobe is the dominant hemisphere. There's some speech function contained in that for most people. However, this was still in a location that we thought it was safe. So the tumour was removed, and the histopathology at that point, this was even before we were testing for 1p19q, was that of an anaplastic oligodendroglioma. So that's really two things. We could also call that an oligodendroglioma with a WHO grade of 3. But there are a few of the features that we could see that were typical of oligodendroglioma, in particular the pattern of the blood vessels within the tumour, what we call chicken wire vasculature, and what we call perinuclear halos, which is where the way that the cells appear. But there were also some features that suggested that this was a tumour that was growing relatively quickly, and that's what we call necrosis and also microvascular proliferation. But some of those features are also seen in other tumours that are much more aggressive and have a much more significantly poor prognosis. So really, so this guy went on and had chemotherapy and radiation, and he remains disease-free 20 years after his surgery. So he was in fact the first patient at Royal North Shore that we tested for this thing called 1p19q. What this is an example of some of the testing we do. The bottom is what we call FISH analysis, which stands for fluorescence in situ hybridization, where the tumour specimen stained in a certain way and looked at such that we can tell whether or not this genetic change is present. And therefore now it's what we need to diagnose these tumours as an oligodendroglioma. Is that important? It's really important, right? That we audited 20 years of experience with oligodendrogliomas and published this 10 years ago. And what we found is that obviously the grade's important, the WHO grade, so those tumours that were grade 2 versus those that were grade 3. Just to orientate you with this curve, this is what's called a Kaplan-Meier analysis, where this is time along the x-axis and the percentage of the patients who are surviving on the y-axis. So the fact that there's more of these patients alive as time goes on is means that there's a more positive prognosis. Then when we analysed irrespective of the grade, so whether it was grade 2 or grade 3, we found that the patients who had what we were testing for, loss of heterozygosity, but the 1p19q change at that time, that in itself was a predictor of outcome. And as you can see, this on the x-axis here, we're talking survival in years of over 10 years, irrespective of the grade. And then when we looked more closely at the anaplastic oligodendroglioma group, we found that in those patients who had loss of heterozygosity or had the 1p19q change, the median survival, that is where 50% of people were still alive, was 15 years, as opposed to those who did not have the 1p19q changes, where the average survival was only about a year or so. And that's more in keeping with what we would expect with a tumour called glioblastoma, which is a more aggressive tumour and is more of what we call an astrocytoma. So this highlights how important these pathology tests are. So for us, that really makes us have to kind of contemplate the way we do surgery beforehand, because we don't want someone who's got a tumour that's relatively slow growing having an extensive operation that may lead to a new neurological deficit. So again, we have to have this in our mind. As I was saying, the glioblastoma, like the patients who do not have 1p19q co-deletion, we didn't have the IDH mutation when we did that audit, but probably some of those patients fell into this group. as opposed to those that are oligodendrogliomas. So when patient 2 comes along 10 years later, when I'm a consultant by this stage, she has this diffuse tumour, young patient, relatively well from a neurological perspective, but this is the tumour, this sort of darker area of the brain, and within it there's some areas where the contrast is taken up, where there's contrast enhancement, and that implies that they're the more high-grade areas of tumour. It's pushing the brain right across. There's blood vessels running through it, including a very important artery called the basilar artery. The tumour extends in front of the brain stem there. So when we talk about surgery and surgery for all glioma, we talk about performing what's called a maximal safe resection. So we want to remove as much tumour as we can whilst keeping the patient in the best neurological condition they can be. And now sometimes that is what we call a gross total resection, where we remove all of the MRI abnormality. But sometimes we're a little bit more, we err more on the side of caution, removing as much tumour as we can, but keeping the patient in the best condition possible. Looking at this scan, there were a number of features that led me to believe this might be an oligodendroglioma, the patient age particularly, and the fact that she presented with a seizure. So knowing that and knowing the possible risk, I was relatively conservative with the surgery. So what I did was remove a fair amount of the lump, but leaving some of this tumour that was going into the much more dangerous area where the blood vessels were involved, and where the brainstem is. And you can see this brainstem is still deformed there from the tumour pushing in like that. And then over to the rest of the team for chemo and radiation. This did prove to be an anaplastic oligodendroglioma. It had that IDH mutation I spoke about, and there was loss of 1p19q. So she's gone on and had radiation and chemotherapy. And as you can see, there's a bit of the white, the contrast enhancement here during the radiation in some of this residual tumour. But as time's gone on, at 6 months, then at 12 months, 2 years, and then at 3 years, you can see that that deformation that we were seeing before of the brainstem is gone. The tumour's basically melted away with the other treatment. So this is a great example of where surgery, where we err on the side of caution and keep the patient in a good neurological condition, is likely to have been to a benefit. So when we talk about surgery, what are some of the concepts? Well, it's not about getting it all out. And that's where we go back to that first slide of the localized tumour versus a diffuse tumour. I can remove all of an MRI abnormality, but I know hand on heart that that's not removing all of the tumour. There will be tumour cells beyond that, and the way to control or slow their growth is with the other treatments at the hands of people like Dr. Back and Dr. Lee. Some of the other factors in decision making, patient factors, the symptoms, the age, and their neurological function. Sorry for the error on the slide there, but also tumour location, and then some of the radiological features and how the tumours look on CT or MRI, as in the first case example. So when it comes to when we reoperate, most of those considerations still hold. Obviously their age, how well a patient is, and then of course what previous treatment they've had and what treatment they've responded to. But other tumour factors include the interval since the initial surgery, and then the pattern of recurrence, whether the tumour is, whether it's occurred within previous radiation fields, whether it could be a radiation effect, or if the tumour's started to involve more of the deep structures in the brain, then perhaps we'll try further chemotherapy, or occasionally further radiation therapy in preference to further surgery. Of course, the other reason for repeat surgery is to obtain more tissue. That's something we need to do sometimes because these tumours do change or can change with time in terms of their resistance to treatment, and that can provide us with more information, getting another tumour sample either by further resection or by biopsy. So firstly, what can we achieve with surgery? Obviously, the main reason is to find out what we're dealing with, but we always go for that maximal safe resection. We make a best educated guess with the emphasis on education at the likely pathology and then tailor the surgery to that. And repeat surgery is often beneficial, particularly in oligodendroglioma as compared to other types of glioma. But this is a multidisciplinary discussion where people like Dr. Back, Dr. Lee, myself, my other neurosurgical colleagues, other colleagues in radiation oncology and medical oncology all get together and discuss things and make a decision about what we think is the best way forward. Thank you all for the privilege of presenting today. I hope that there's been some useful information there for you, and I look forward to participating in the Q&A session later on.